get to Jersey from Boston.
Oh my Why were you in Boston?
First, it was snowing in Boston, so there were a lot of accidents on the road. And then by 3:30, I was on 84, and then it quickly became dark, and it was raining. And when I crossed Connecticut, I had two choices to take: either 287 towards New Jersey or go through Yonkers and cross George Washington Bridge. So I went to New York because it was shorter. And that was a mistake. I hit a pothole. It was so big, I thought my car broke down. But I busted 2 tires in the pothole, and 7:30 I was stranded somewhere there, and AAA came at 11:30 at night.
Oh my God.
Can you imagine? 4 hours later.
That sounds miserable.
And they wouldn't take me back to New Jersey. They said, we won't drive in this rain, so the best we can do is take you to a tire shop. I said, okay. So they took me to this tire shop, and now he doesn't have, the right size tires. And the tires that I have could not be fixed because they were just broken. So he put wrong size tires on my car and old used tires. He said, go home slowly.
How did you get here this morning? How did you get here this morning? Slowly?
No. That was another car. And so it took me another hour and a half just to get from Yonkers back home. And yeah, you should see that car. It doesn't even stand straight. There's a big tire and a small tire. I don't know why they put spare tires in the cars anymore. They give you this cute little kit that's supposed to fix tires, and it doesn't do anything.
Why were you in Boston?
Oh, I had to go. My daughter lives there. So went to see her, and then it started snowing. So somewhere here?
Yeah, like 33-ish.
Mm-hmm. Okay, let's start from here. All right. So what's the outcome of an acute inflammation? It's usually 100% complete resolution. If you get an injury or an infection, the usual outcome is that if you treat it well, there's 100% resolution. Usually there's no scar, and everything is back to normal. May take a few weeks, but everything gets better. The second outcome is a scar, where there's formation of granulation tissue, and then this granulation tissue will slowly, go through a process of neovascularization and lots of fibroblasts and fibrin threads will form a new, tissue, which is called a scar tissue. Now, scar tissues will persist, and scars will take many, many years before they become, before they won't completely disappear, but where they almost disappear. Really depends on how big the scar is. Like surgical scars will never go away, right? And but if you have a smaller injury, if you have a smaller, infection, like in tuberculosis, if you treat it well, you can get away with minimal scarring. But if tuberculosis stays, then of course there'll be a lot of scarring, lots of non-elastic tissue, more collagen fibers than elastin fibers, and so on. Or it could progress to chronic inflammation. What progresses to chronic inflammation usually? What kind of infections? Usually it's bacteria that are intercellular, right? Now, what kind of bacteria are intercellular? Tuberculosis, right? That is a big example of a bacteria that lives inside your white blood cells. And so it escapes all kinds of attacks. Your immune system does not see the bacteria, that's why it cannot attack it. It lives inside the immune cells. So, which is why you get chronic inflammation, and chronic inflammation is a whole different process. Now, morphologic patterns of acute inflammation is usually formation of an exudate. This could be watery, it could be full of fibrin, right? One of the things in an acute inflammation is formation of fibrin, right? Which is part of your coagulation system. So fibrinogen, which is factor 1A, converts to factor 1, which is fibrin. And then fibrin threads, they form the initial plug, they cover the site of injury, and then they also bind to platelets and form the platelet plug, and so on. And also, when you have the exudate is also full of your fibrin threads, right? Because the first thing that happens, what's the first thing that's going to happen in an inflammation? The permeability of the vessel will change. The area where you have inflammation, the area where you have the injury or the infection, the vessels will become more leaky there, right? That's the first thing that's going to happen. And why do they become leaky? What makes them leaky? The sentinel cells in your ECM. Remember the role of ECM. I mean, your organs are important because they are providing you with all the functionality. But the ECM is the environment in which the organ lives, right? So ECM is kind of important. It's got all these collagen fibers, it's got elastin fibers, it has these, what do you call this, proteoglycans, and it has hyaluronic acid, and then it has a bunch of these white blood cells, right? What white blood cells are in the ECM? Any ideas? You have dendritic cells, you have tissue macrophages. Together they are called histiocytes, right? So you have histiocytes, and then you can have natural killer cells. Natural killer cells are different from your macrophages and from your dendritic cells. How are they different? Because dendritic cells and your tissue macrophages, these are myeloid in origin, right? Whereas lymphocytes are lymphoid, your natural killer cells are lymphoid in origin. So their precursors are different, right? Erythrocyte precursors will form monocytes. And monocytes are your macrophages and dendritic cells, the macrophages in your blood, the tissue macrophages, as well as tissue dendritic cells, which are your sentinel cells. What about natural killer cells? Natural killer cells are lymphoid in origin. What does that mean? They come from lymph, And what other cells are lymphoid in origin? Lymphocytes, right? T lymphocytes, B lymphocytes, they are also lymphoid in origin. So you get your natural killer cells from T lymphocytes. These are modified T lymphocytes that live in your ECM, right? Not just in your blood, but you have these immune cells in your ECM which protect the ECM from all kinds of toxins.
So would that fall under the sentinel?
Yep,
Okay.
they're all sentinel cells.
Okay.
Then you have giant cells. What are giant cells? Giant cells, you have these mediators of inflammation. What they do is, as soon as there's an inflammation, they start combining these sentinel cells and form these large giant cells that are super, pro-inflammatory. So all kinds of stuff will happen during inflammation, and then these sentinel cells, to protect your ECM, they will initiate this process of inflammation by releasing all kinds of mediators, and these mediators will then act on your blood vessels and increase their permeability. So the first thing that's going to happen is these sentinel cells in the ECM will release mediators that will, what mediators will cause vasodilation? What's the first mediator? Histamine, bradykinin. These are the ones that will cause vasodilation first. And then you have all kinds of pro-inflammatory mediators that will be released. Some of them are chemoattractants, so they will start summoning other cells towards the site of inflammation. And then you have exposure of you have your other white blood cells which are in your blood vessel. They are exposed to the ECM, and now they start rolling. You know how leukocytes will start rolling and marginating and then going to the ECM. So we already discussed that. So you can have a fibrinous swelling. Now fibrinous will have hemorrhage, so it will be reddish. It will be rich in fibrin and platelets. You can have suppurative. What's suppurative morphology? Suppurative means it's full of pus, right? So pus is also an outcome. And then it could be ulcerative. Ulcerative means that the wound does not heal. It turns into an ulcer. Ulcer means that it involves all the layers of your skin. So the most common is serous. And then you get fibrinous. Suppurative is usually seen when it starts to become more chronic. Then it becomes suppurative. An example of suppurative inflammation would be where there's a lot of pus. Middle ear infections. Have you seen kids with middle ear infections? They have pus coming out for years. Once it becomes chronic, it becomes difficult to treat because the bacteria, it goes and hides in the mastoid cells in the bone of in the parietal bone. So, so that is an example of suppurative inflammation. And then of course you have ulcerative. So this is a serous blister. This is full of clear fluid. You can see the redness around it, and this will also be warm, and this will also be tender, and it will be stiff. This is fibrinous. You can see how it's reddish, and it's more like a, it'll be sticky and not liquidy at all. So hemorrhagic and full of fibrin. You can see here how it would appear with an H&E stain. This is suppurative. So this is usually seen in chronic inflammation, or also known as purulent. That's just a microscopic picture. And this is ulcerative, where all the layers of skin will be involved. So sequence of events once more, just to, quickly revise everything. I think sequence is important because once you know the sequence, you know how inflammation would go. So you have normal histology, and then something disturbs the normal physiology, like a toxin or an injury or pathogen. Something disturbs the normal histology, and then the first thing you have is vasodilation, increased permeability, leakage of exudate, margination, rolling adhesions of neutrophils. Then you have transmigration, diapedesis. This is when the neutrophils will move to the ECM. Then you have chemotaxis. So lots of mediators will be released, and they will start attracting everything. There's another thing we remember. We talked about von Willebrand factor back in physiology, or did we not? No?
What was it?
Von Willebrand factor? Von Willebrand factor is when you have tissue damage, especially vascular damage. The vascular endothelium basically forms the inside lining of your blood vessel. So when the vascular endothelium is disturbed, there's a protein called von Willebrand factor, which gets exposed, which is under the endothelial cells. This von Willebrand protein or factor then starts attracting fibrin. So fibrin starts to attach to this von Willebrand factor, and then also activates platelets. So platelets get activated, they start binding to this von Willebrand protein just to cover the area of the injury. And then it activates the platelet, because platelets are not active when your blood is flowing normally, when there's no tissue damage. Once it binds to von Willebrand factor and once it binds to fibrin, it becomes active. What does it do when it becomes active? It starts releasing stuff, right? And it starts aggregating, starts binding to stuff. That's what platelets do. They have to cover a injured area. They have to form a plug. So they start sticking to each other. They start sticking to fibrin, and then they also start releasing mediators, right? Can you name a few mediators that it releases? It releases ADP. It releases thromboxane A2. It releases serotonin, and so on. All right, so chemotaxis is the next step. What is PMN? Another name for neutrophils, right? So neutrophils are activated, and once they are activated, they have a very broad spectrum of activity. They will release lytic enzymes, right? That will go and destroy the surrounding tissue, especially the bacteria and other pathogens, or other harmful proteins and molecules and so on. And then it also starts engulfing them and phagocytosing them. And then it also releases all kinds of mediators of inflammation. And then once neutrophils become activated, it starts the phagocytic process. There's recognition of the pathogen or the harmful molecules, and then attachment to them and engulfing and killing them. Killing means it goes to the lysosome inside the neutrophil, which is full of these lytic enzymes. And then, of course, there's degradation or digestion, and then finally termination of the inflammation. There could be 100% resolution, scar formation, or it could turn into a chronic inflammation. Now, systemic manifestations of inflammation. You can have fever. You mostly have fever, right? The first thing in an inflammation is fever. Mechanism is all these cytokines. They stimulate prostaglandins, and prostaglandins they basically change the temperature set point in your hypothalamus, right? Temperature is controlled in the hypothalamus, right? So the temperature control center of the hypothalamus is set to a new high point, and so the person gets fever. Leukocytosis, all this, white blood cells will be formed. Now, not only are the white blood cells summoned to the site of inflammation, but you have these, cytokines, which will get to the bone marrow and stimulate the bone marrow to produce more white blood cells, right? So, TNF, tumor necrosis factor, this is a cytokine which is mainly involved in leukocyte release from the bone marrow. Now, there's other proteins which are also released by your white blood cells, especially macrophages and T cells. They are called colony stimulating factors. Did we talk about colony stimulating factors? And then you have CSF, which is your granulocyte macrophage colony stimulating factor. I think we did last semester. Anyway, so your macrophages and T cells and other white blood cells, they also produce CSF. These are proteins which are called colony stimulating factors. They specifically go to the bone marrow and stimulate the production of white blood cells. So both GM-CSF, which is mostly for granulocyte macrophages, and then you have G-CSF, which is just your granulocyte colony stimulating factors. Both kind of proteins are released, and they will go to the bone marrow and they will increase the production of white blood cells. Now, increased plasma level of acute phase reactants. What are acute phase reactants? These cytokines then go to the liver, and in the liver it increases the production of certain proteins which are called acute phase proteins or acute phase reactants. One of the most important one is C-reactive protein. Have you heard of C-reactive protein? When you do a blood test, one of the things that you see in the blood test is a C-reactive protein. C-reactive protein is a marker of inflammation. So when somebody has a fever or an infection and you do a blood work, always look at the CRP. When you look at the CRP and the CRP is high, it shows you there's an acute inflammation going on, right? So CRP is one of the acute phase reactants. It's stimulated by the liver along with several other acute phase reactants. And these basically are your markers for inflammation. And they are released by the liver in response to different cytokines and interleukins. So C-reactive protein, a marker of inflammation, then you have fibrinogen, serum amyloid protein. These are all your acute phase reactants, and they will all be increased because the liver is stimulated to produce these. And then of course hypotension can occur. Why does hypotension occur? Yes. Not in small time inflammation. You won't get hypotension if you have a chest infection or a small time inflammation. Hypotension occurs in septic shock, right? Septic shock is the biggest inflammatory process your body can be exposed to. So you have toxins in your blood. These are usually bacterial breakdown products, and these will start an inflammation that, yep.
Does this occur in anaphylaxis as well?
Okay. No. Septic shock is different. Anaphylaxis is an acute response to, an allergen, usually.
Cause vasodilation?
It does cause vasodilation. That's why it could be part of that, but septic shock is usually more slower. Anaphylaxis is quick. It's usually anaphylaxis is mediated by IgE. responding to some allergen which the body does not like. And IgE then binds to mast cells, and it's the mast cells and basophils which start the anaphylactic reaction. But septic shock is your body's response to bacterial products. And so what happens is in septic shock, there's massive vasodilation. And then what happens is something called DIC, which is disseminated intravascular coagulation. What happens is because of these bacterial products all over your blood circulation, your platelets will get activated. And these platelets will start aggregating all over throughout your circulation. And these, these will start depositing in your organs, and they will start depositing in your blood vessels. So the blood flow will be affected, and now you suffer from a condition called thrombocytopenia. Although you have platelets in your body, there's no deficiency of platelets in the body, but all the platelets are being used up in forming these plugs against these bacterial products. So although you have enough platelets, but they are all clumped and they are not in your blood anymore. So you suffer from thrombocytopenia. What happens in thrombocytopenia? If you already have vasodilation, you worsen the situation because now your blood won't clot anymore. And so the patient will die of internal bleeding. So hypotension, and then hypotension followed by DIC, which is disseminated intravascular coagulation. You can have generalized edema, and then organ failure. So this is the worst outcome of inflammation, by the way. The worst outcome is DIC. When do you see DIC usually? The most common reason for DIC is childbirth. It can lead to DIC and is potentially fatal. There's once a patient develops DIC, there's no coming back from there because all the blood just coagulates, and then the patient has thrombocytopenia, and then internal bleeding and so on, and massive vasodilation. You know that your endothelium has anticoagulant properties. And once the endothelium gets disturbed or endothelium gets activated by some toxin or chemical or anything, it becomes procoagulant. Once it becomes procoagulant, it starts to promote coagulation. And now the whole problem starts when your endothelium becomes procoagulant. So once you have a systemic inflammation, the endothelium of most of your blood vessels, it becomes procoagulant. And so it helps in coagulation of blood, and that's why you get all these platelets get activated and they start clumping together. Now, high levels of TNF are found in people who have DIC and in people who have, systemic, hypotension and stuff like this. And so TNF is the main cytokine which basically causes this. But there are other cytokines also involved, and together they, just make your blood clump together and cause DIC. So DIC is life-threatening. If it progresses, if it becomes severe, patients will usually die. It's very difficult to save patients from this. All right, moving on to chronic inflammation. Now, chronic inflammation is not neutrophils anymore. When inflammation becomes chronic, you usually see monocytes. So monocytes, you have macrophages, which are in your blood, and then you have histiocytes in your tissues. So what are histiocytes? They are tissue macrophages and dendritic cells. they have myeloid, they are myeloid in origin, come from red blood cell precursors. From the bone marrow, right? So you have lymphocytes and then you have monocytes. So these are basically your main cells of chronic inflammation. What are the causes of chronic inflammation? Persistence of infection. Exposure to insult, prolonged exposure to insult, or injury, and autoimmunity. Sometimes your immune system, the T cells and the B cells, they just start acting up and they start reacting to some self-antigen, right? Every cell of your body has small receptors on them which the B and the T lymphocytes recognize as self-antigens, right? So like a green light, every cell has a little green light on it. So when the immune cells, they start looking at cells, and they're always looking at cells. So long as they can see the green light, they know this is our cell, and they don't need to attack it. Sometimes your lymphocytes, they become colorblind, right? So they don't see the green light. Now they see a green light, but they see it as red, and then they start attacking it. So these green lights are receptors which are called self-antigens. If your immune system does not see self-antigens, it will attack them. And this is the concept of autoimmune diseases, right? So autoimmune diseases are because your immune cells, they don't see self-antigens anymore, or a certain kind of self-antigen. And then it starts attacking those cells. So autoimmunity will get activated, and now they can train your immune cells so that they will start recognizing the self-antigen, or they can train them to attack certain cells that do have the green light, that do have self-antigen. The monoclonal antibodies, have you heard about them? Right, it's a new type of treatment. It's becoming very popular. What do they do? What are these monoclonal antibodies? These are antibodies that are trained to see certain cells. Even with the green light, they will see them as foreign cells, or they won't recognize them as self-antigens, those green lights. So they will start attacking them. So they've started curing cancers with monoclonal antibodies. They've started curing certain autoimmune diseases with monoclonal antibodies. I think it's a great way to go, because these monoclonal antibodies, the way science is going, they can now get into your genes, they can change the sequence of the amino acids and make your cells produce better proteins, better antibodies, and so on. So cells involved in your chronic inflammation, lymphocyte, right? Lymphocytes will also produce natural killer cells. So lymphoid origin, right? Macrophages. Macrophages in tissues are called histiocytes. Now, macrophages also form other phagocytic cells, such as epithelioid cells. Now, don't get confused by all these names, right? If somebody says epithelioid cell and then you say, oh, here's another cell I don't know about, it's nothing but a macrophage. It's just the location which changes their name, right? So epithelioid cell, where do you think they will be present? Right? In the skin, right? Or in most of your epithelial linings. So they are called epithelioid cells. What are they? They are just macrophages. Where are they? They are in the ECM. And what do? They protect the ECM against inflammation. So you get tissue. So I remember I used to get so confused because you learn about these white blood cells, and then somebody says histiocyte, and now you're okay. What is a histiocyte? So familiarize yourself with these names. They're not difficult. They're just even neutrophil. You have like 10 different names for neutrophil. I don't know why you want to be so friendly with neutrophils. Just call them one name. Same thing for monocytes, same thing for other cells. So lymphocytes, you see macrophages, and once there's a chronic inflammation, these macrophages in the tissues, in the blood, they proliferate. So you have lots of them. So histiocytes will increase in chronic inflammation, epithelioid cells will increase, and then all kinds of other sentinel cells will also proliferate. Plasma cells. Here's another name that will confuse you. What is a plasma cell? It's nothing but a B lymphocyte. So it's a B lymphocyte which starts producing antibodies. So you have inactive B lymphocyte, which is called a B lymphocyte, and when it becomes active, starts producing antibodies, it's called a plasma cell. Then you have giant cells. What are giant cells? Giant cells are when your cytokines will start fusing these immune cells together. So fusion of a macrophage, a monocyte, and an epithelioid cell will give you a giant cell. And why do you have to join? Why do you have to fuse these cells? To form a super inflammatory cell. So it does the job of 3 different type of cells. Which is why you see giant cells in chronic inflammation, right? Because the body is trying to get rid of this inflammation. It's trying everything. It's proliferating these histiocytes, and plasma cells are increasing because now you need a lot of B cells to produce antibodies, and then you have these proliferating epithelioid cells. And similarly, your interleukins will start fusing these cells into these giant cells. These are super inflammatory cells, just in an attempt to curb this inflammation. So you see all this when you have chronic inflammation. In acute inflammation, the body gets rid of inflammation before it's able to proliferate all these cells and start forming giant cells. So you don't see a lot of these in acute inflammation. And what is the definition of a chronic inflammation? When would you call an inflammation chronic? After 1 day? 1 week?
6 months, 6 weeks.
Not really. So if it's more than 3 to 4 weeks, then it becomes a chronic inflammation. Of course, 6 months is for some diseases like tuberculosis. You would go 6 months before calling it a chronic inflammation because it's a intracellular bacteria, and it's a slow progress. It develops slowly. So you would have symptoms and then signs of inflammation, but it takes a while before it turns into. If you see tuberculous granulomas, initially you don't see a lot of them because they are sitting inside the cells and they don't really start off a full-blown inflammatory process. But as it progresses, you start to see these granulomas, and these granulomas are signs of chronic inflammation. And then you have eosinophils, you have mast cells. So all of these are cells of chronic inflammation. Some of them will be there in acute inflammation, but in smaller amounts. Mostly they will be seen in large amounts in chronic inflammation. But you don't see neutrophils here, right? So you should be able to differentiate an acute from chronic inflammation just by doing a blood test, right? If you do a blood test and you see high neutrophils, there's acute inflammation. Now, if you see high lymphocytes and not neutrophils, doesn't mean that this is chronic inflammation. It could be chronic inflammation, but also viral inflammations or viral infections, they somehow don't trigger neutrophils. They mostly trigger your lymphocytes. And why is that? Because your B lymphocytes, they have memory. So B lymphocytes, they have information about all these viruses and other pathogens that frequently attack you. So as soon as they attack you, before neutrophils can take over, they just start producing your antibodies. So lymphocytes will proliferate in certain infections, repeated infections, especially viral infections, where your body already knows is familiar with these infections. So it's ready to produce all these antibodies. So you do get lymphocytic proliferation in some viral infections. So morphology is infiltration, tissue destruction, healing, and then fibrosis. Yes?
Why do neutrophils stop being released into the blood for chronic? Is it just like they're not really doing anything, so the body stops releasing them?
Okay, so once your immune system takes over, it's much, much stronger than your neutrophils.
Okay.
Your T lymphocytes have multiple functions, and they produce thousands and thousands of these TH proteins, and it produces these cytokines and even interferon and all kinds of stuff. And then you have the other type of T cells, the CD8 cells, which are very cytotoxic, and they are also, phagocytic. So once your immune system takes over, then it just supersedes everything else. So neutrophil does not remain your most active form of inflammation because the lymphocytes take over.
Thank you.
Okay, so now we have, let me know when you need a break. Maybe 5 more minutes? So this is what happens. There'll be infiltration of all these cells, tissue destruction, healing, and fibrosis. Tissue destruction is something that usually happens in chronic inflammation. In acute inflammation, usually there is no tissue destruction and there's minimal scar tissue. In chronic inflammation, there'll be more tissue destruction and more scar tissue. What is scar tissue? Fibrin, collagen fibers. Now there's different types of collagen fibers. There's like 25 different types of collagen fibers in your body. So, I forget where they were, but I think lungs have collagen too. We'll come to that. So different kind of collagen fibers will develop. So when you have a chronic inflammation, there'll be more fibrin, there'll be more granulation tissue. Fibroblasts, yes. So you have a lot of fibroblasts, and fibroblasts will produce collagen fiber. Not the right kind, but it will bridge the gap, and it will, make the, it will at least preserve your organ or the ECM. And then you have all these neovascularization, because it took a lot of time to heal. It's chronic, so there's a lot of neovascularization. Because when your body starts to heal something, like a tissue or something, a lot of growth factors are released, and these growth factors will form fibroblasts. They will form new cells, and they will form new blood vessels. So there'll be a lot of new. I think we'll come to this now. Let's just go with the slides. So one of the outcomes of chronic inflammation is a granuloma. Now, when you see granulomas in a tissue, know that there is chronic inflammation, long-standing inflammation, like tuberculosis. Tuberculous granulomas are diagnostic of the disease. So if you do a chest X-ray and you start seeing granulomas, you will know that there's only 2 diagnoses, right, if you see granulomas. One is tuberculosis, the other is sarcoidosis, right? Both are inflammatory diseases. But sarcoidosis patient will not have fever, night sweats, and all kinds of other symptoms. So you correlate with symptoms, and granuloma will lead to you're diagnosing tuberculosis. So what's the 4 components of a granuloma? You will see fibroblasts, right? What are fibroblasts doing? Trying to create new tissue, right? And lots of collagen fiber, lots of ECM products are being produced by fibroblasts in order to recover the tissue. You see lymphocytes. What are lymphocytes doing? They are trying to attack the offending agent, so the pathogen or the some offending molecule or something. So lymphocytes have taken over now. from neutrophils. Then you see histiocytes. Histiocytes are sentinel cells, right? They are your dendritic cells and your tissue macrophages. And then you see a lot of giant cells. So granuloma will be full of giant cells, which are your super inflammatory cells formed by fusion of other immune cells. So 4 types of granulomas are common, the most common being your tuberculous granuloma. Next will be your sarcoid granuloma in sarcoidosis. Then fungi will, because fungal infections always tend to be chronic. Fungus does not leave you. So it's very, very difficult to treat fungal infections, and so they always tend to become chronic. So once it becomes chronic, it forms a granuloma, and that's a fungus granuloma. It'll be different from a sarcoid. It'll be different from a tuberculous granuloma, but that's what you see. And then of course you will see foreign bodies or foreign offending agent or the pathogen that is causing the chronic inflammation, right? So what do you see in a granuloma? You see giant cells, you see histiocytes, you see lymphocytes, and you see fibroblasts. That's your morphology of your granuloma. And what are the different types of granuloma? You have tuberculous, sarcoid, fungal, and then you have granulomas around offending agents or foreign bodies or something that cannot be removed. Granulomas can be caseating, which is cheesy appearance, or could be dry, or non-caseating, which you see in sarcoidosis. So caseating is usually in tuberculosis, and then non-caseating is in sarcoidosis. Now, once you have chronic inflammation, your lymph nodes become involved in, because you have blood flowing in your blood vessels, and then the fluid, the extrastitial fluid. Where is the extrastitial fluid? In your ECM, right? So that has to go somewhere. So it goes through the lymphatic channels. Now, if you have inflammation in your ECM, where would it go? All the inflammation would be drained through the lymphatic channels, which is why your lymph nodes and your lymphatic supply becomes very, very important when it comes to infection or inflammation, because now your ECM becomes full of fluid, right, because of the exudate. And now you have all these white cells and everything, all the inflammation going on in the ECM. So you can have pus, you can have all kinds of debris from this inflammation. Everything has to be drained through the regional lymph nodes and the lymphatic channels. So now, another thing in chronic or acute inflammation is lymph node. They become palpable, they can become tender, local lymph nodes, right? So when you're looking for an inflammation, you always check for lymph nodes to see the extent of inflammation. If you find swollen lymph nodes, it means that this is quite a sizable amount of inflammation which is causing swelling of the regional lymph nodes. Now, just to have more information, tumors also do the same. Tumors also drain through your lymph nodes, which is why if you see lymph node swelling in tumors, what does it signify? Metastasis, right? Because now the tumor is draining through the lymph nodes, and the tumor cells are going to other places in the body, which is when you do surgery for a tumor, they not only remove the tumor but also remove all the regional lymph nodes. And that's the reason, because the metastatic cells are in your lymphatic system. So these are some of your acute. This is serum protein electrophoresis, just to see which proteins are present in an exudate in your blood, and you see all these acute phase reactants. So, yep, all of these are your acute phase reactants. So You have fibrinogen, haptoglobulin, C-reactive protein, complement C3A, serum amyloid A, alpha-1 glycoprotein, alpha-1 anti-protease, transferrin, alpha-2 macroglobin, ceruloplasmin. They are all acute phase reactants. They are markers of different types of inflammation. But C-reactive protein is the most common among them. C-reactive protein is mostly raised in all kinds of inflammation. Then you have certain different kinds of inflammations in which different types of these acute phase reactants might be increased. You don't need to go into a lot of details. When you study medicine, and medicine is study of disease and how you diagnose, how you investigate, and how you treat. We are just doing the, the pathology part. When you study medicine, you will learn about diseases and what kind of, what to expect in different blood reports and which, what goes up, what goes down. You read all about that when you do medicine. But remember all these acute phase reactants. Now in inflammations, usually your alpha-1, alpha-2, these will be raised along with your C-reactive protein. Now here you see albumin going up, alpha-1, alpha-2, this is beta, where is it? Not here. So different types of proteins going up. Take a break and then we'll continue.